Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about anterior knee pain and some things that could be labeled umbrella terms, but patellofemoral pain syndrome, Sinden-Larson's, patellar tendinopathy, and good old Osgood Shlatters there. But before I get too much into it, Brandon, how's it going?
Going well, man. We are doing a nice morning show here again, which I just realized I have coffee again. We got to stop doing these morning shows. What do you have? If you have a beer,
I do have something.
All right.
My main
I'll
man,
run
Justin.
and go get one.
Huh?
I said I'll have to go run and get one.
Yeah, well, I guess I can talk about it. This is Yards, which was one of my favorite breweries. This is from Justin for Friends Gaming. He gave me 2 beers. The other one will be featured on this show. Long John's. Justin says that pretty much every day in the clinic. He's got that South Jersey Philly vibe about him. He's references Jawn for just about everything. It's the perfect word to describe people, places, things. That Jawn over there, going to that Jawn, Jawn everything. So we always crack up about it, and he hooked me up with it. It's a winter lager from Yards, which is in Philly. Anybody in the Philly area, I highly recommend that brewery. Let's crack this open.
So I missed it. What's the official name? What, John?
Long John's, like having John's, the winter lager, but John's is spelled Jawns.
Yeah, I remember the first time I heard the word John. I was an undergrad at Temple, which is the lovely shirt you're repping there. And my roommate at the time was like, he was just talking and he kept saying John, this John, that John. And I'm like, finally I was like, dude, what are you saying? And he's like, oh, it's a John. He's like, you've never heard that? I was like, no. So then he explained it just like how you do. He's like, it could be anything you want it to be. Anything. Noun, adjective, verb, whatever.
Anything. So great. And it makes sense. Like you say it to people around, like who aren't familiar with it, and that it just instantly makes sense. He's like, oh, he's talking about the remote over there.
Yeah.
Like, look at that pretty John over there. It's like, oh, pretty gal across the street. So that's how I knew it in college. Was like we were talking about someone attractive, but that's how it was. But then Justin enlightened me. He's like, no, it's everything. So let me taste this out of my Yards cup. Fitting, nice dark beer. He knows what I like. Oh, it's good. That is winner in a cup right there.
There it is.
It's good. I'm gonna give it 8.3.
Oh, it's getting up there now.
It's getting higher up there.
Yeah.
Dark beer. I like winter lagers. Usually a lot of them are even lighter or like brown lagers. So this is more, seems like it's more of the porter stout family. Doesn't say the grand details on this, but I'm a fan. Thank you, Justin.
Very nice. I went and got a quick Don Q Anejo XO, just real quick, because we're on I have coffee here too, so I'll be flopping between the two. Early morning podcast. We got to start moving these back here, but next week I got some beers that I want to crack open. You got me some as a thank you, so I want to break those open. I have some from Hoboken Brewing as well, so I want to break those out for the show. So next couple shows that we have, I'll definitely break those out. It's been chaotic with all the courses and the new offices, and we're kind of ramping up, and so this weekend's the last one that we're having for the next couple months. So after this, I kind of get a little breather and get to line some things up. So we'll be better for that. Yeah.
Cool.
Got my tea mug here. Cheers. And then my little bullet shaped ice cubes.
Really?
Yeah, you just stick them in like metal. You just stick them in the holder and they freeze over.
That's cool.
So yeah, they work out well.
Yeah, they don't water it down or anything like that. It's
cool. Though actually, sometimes by the end of a drink, I do kind of like the water and whatever I'm drinking, especially if it's like a bourbon or a whiskey. Sometimes it adds a nice little flavor to it.
Yeah. And then hydrates you a little bit, especially if you had a couple too many.
Exactly. All right. So we're talking about the umbrella terms. I mean, you named the
big
you named
boys.
several of them, the official names. I'm going to
throw
go
in
and say
plica syndrome too into that.
Yeah. Did you say fat pad too?
I did not say fat pad.
Fat pad syndrome, all these kind of umbrella term diagnoses. I would say, PFPS, fat pad, plica is all umbrella type stuff. Obviously I think I'm blanking out right now. What is that? The patella tendonitis for
jumper's knee, patellar tendinopathy. Osgood Shlatters.
There we go. I don't know why I'm blanking out. Osgood Shlatters.
Because they're all similar,
Probably, obviously it has more mechanical properties to it and things like that. But I guess we're here to talk about expanding your treatment, getting away from what's been done, treating the diagnosis instead of treating the diagnosis, let's treat the impairments. When you're hitting that wall and you've done X, Y, and Z for 5, 8, 10 sessions, and maybe that patient got a little better, maybe they didn't at all, but they're hitting the wall. Where do we go from there? We have some articles that we're going to reference that talk about treating regionally, and then we're also obviously going to bring our joint-based approach to it. And it's not necessarily pain sciencing the patient, and that much of a how much is this limiting the patient? Well, what can we do to modulate pain, and then do some other things there? So that's going to be the basis of our show. Jer, I'll throw the first question out to you. How do you like to see these? Especially, I mean, you see more of an athletic population than I do these days, especially with the opening of your second office there in Cherry Hill. So a little plug to Jer. Shout out to Jer. Cheers, man.
Appreciate it.
So what are you getting the super young athletes? I know you're more in the collegiate town, so it's probably past some of those younger diagnoses, and you're probably getting more towards the tendinitises and PFPSs, instead of some of the other stuff.
No, I think it's a good mix. I mean, for referencing headquarters there in Glassboro, we do get, I think, probably our bread and butter is mostly high school athletes, and we do get a good chunk of the collegiate athletes. Or even younger, we have a lot, a decent amount of middle school athletes, which, to build off your point there, to try and pain science a 12-year-old basketball player, you don't really stand much of a chance. They just want to go back and play, but it hurts them to play. So, I mean, we get the gamut of essentially all these diagnoses, and when you really look at it, I mean, how old was either Osgood Schlatter and Simon Larson? Like, these things were probably made in God knows what decade, and it's really how much value do those diagnoses really give you? It's like, all right, one's pain at the inferior pole, one's at the tib tube. Like, does that tell you how to treat them? It really doesn't. I get a lot of people that say it's like, oh, it's a self-limiting thing. You'll grow out of it. Take some time off. And I think especially the kids, almost all of them have taken time off. They came back, it reoccurred. They're some of them are in the points of tears. And then eventually they come to physical therapy. So, we try and, do a multimodal approach, just like everything else that we talk about on this show. I would admit, especially, early on in my career, we're always reflective. I would treat things, locally, treat the diagnosis. It was patellar tendinopathy or anything of that family. I was probably scraping the patellar tendon, doing I-stem, maybe patellar tendon mobilizations, patella mobilizations. And then I know there was some research articles when I was younger about eccentric loading to the patellar tendon, which is
isometrics.
Yep. People get a little bit better, but it was like, it'd be good. It was good up until like certain points, and especially when they went back full blast, it would come back. And that was the most frustrating thing is like, okay, what else is going on? So now, starting from like kind of a top down approach, we do things where we're focusing on, beyond just motor control. Like that was the other thing. It was just like, my mind was fixed that the whole quad complex was overworking, and it was mostly due to weak glutes. So I'd go glute city. And, but when you really look at it, every freaking teenage kid has weak glutes. Shit, every adult has weak glutes and that sort of thing. I can break them all on MMTs. So once I started realizing that, I'm like, is that really going to help them? And again, sure, it helps to some degree, but really outcome wise, it didn't. So taking it a step further, doing some things to modulate things outside of just, working the patellar tendon. So we do spinal manipulations, a lot of them, going into things of ACLs who, anybody who's treated ACLs for a lot, most of them, in that kind of mid stages, that 3-4 months, they're starting to ramp things up, get back into running. They start to get some, whether it's patellofemoral pain or jumper's knee or any of these other things that we mentioned, and you have to kind of treat that. And it's not the ACL in this case. So doing some things outside of that. And we'll do some lumbar manipulations. I think I do lumbar manipulations on all my ACLs, and all these type of patients. And we'll talk about some research that backs that up. The femoral nerve that courses through that area. So that's something else I see a big, that's a big game changer for a lot of them versus the classic, let me just, stretch out my rec fem, more doing flossing and combining that with lumbar mobilizations, I think has been really beneficial. And then, I'll still do some things in that area. I kind of do it from let's see if I can make a symptom modification sort of way versus let me just do it to treat those tissues. So I do it like, all right, let me play around with the fat pad because the fat pad's there to patellar tendon. Now I'm doing stuff of like, let me do a medial glide to the tibia as they're doing a step down and see if that's relieving them. Or, a patella glide, a medial patella glide during a squat and seeing if that helps them. If that helps them, then I'm mobbing it. And I'll still do some of what research supports in those eccentric isometric loading. So I'm not giving that up, and then transitioning to plyometrics. And something I missed, especially while I was younger, was the ankle. A lot of that, lack of that weight bearing dorsiflexion in a lot of these kids or anybody can lead to a little bit more stress and strain in that anterior compartment of the knee. So make sure we're doing our due diligence and treating the ankle as well. So if I really look at it from a manual therapy route or treatment route, I'm probably doing more techniques at like the thoracolumbar junction and the ankle than I'm doing at the actual knee. Sometimes the hip, I probably don't see the hip as much. Like I don't do as much at the hip.
Limited.
It's still there, especially I would say like anterior glides of the hip. But it's probably back, ankle, hip, and knee, kind of pretty tied. But and then integrating any education, that sort of stuff. But what about you, Brandon?
Well, before I jump into that, I got the answer. Well, the answer via Google about when Osgood Shlatters was created. It was in 1903 by Robert Osgood, a U.S. orthopedic surgeon, and Carl Schlatter, a Swiss surgeon, concurrently described the disease that now bears the name that it is. Right. And it's common in patients who are active adolescents, right? So, like you said,
volleyball players,
jumpers, and not to say that there's probably some type of mechanical or biomechanical changes or biochemical, I should say, changes to maybe some of the structures in there, and I think that goes to, like you said, addressing some of the movement mechanics or deficiencies. And maybe that is by attacking the glutes, or like you said, having them do a functional exercise and maybe tweaking something, adjusting their form, maybe adding a trunk lead so they're loading their hips more. Maybe it's by manipulating their or cueing their tibia, or maybe they're lacking dorsiflexion. So now more forces are going through that knee than there should be. A ton of things there, but just trying to offload or strengthen these patients and having them squat more is typically not the thing, especially if they're younger. I mean, they're active enough as it is. So why are we just going to nail them with more exercises? I never got that. Same thing with Achilles type stuff. Like if it's an overuse injury, why are we just going to use them some more? Right.
And
let's find a way. What happened?
It's usually like what they say is like eccentric loading to it, which is painful in itself on a normal basis. Like take your normal workout and just do eccentrics of it. You're going to be hurt like a ton after that. And now you're taking some ingrained pain and, hammer the same muscles that they use every day in their sport, but go for it. I thought that was a huge point there.
Yeah. And it's not to say that you can't do eccentrics and you can't do isometrics, which yes, there's some research that supports that as well. Obviously it's included in our plan of care as well, but especially for all the movement people who like to squat and are hands off. Speaking of hands off, Meekin had his post the other day saying he's hands off, but not hands off or whatever. I don't know if you saw.
I didn't see it.
Yeah. I found it very, actually a student showed it to me. Let me see if I can just pull it up. Pro hands on. Here we go. This post. Everyone can see. Everyone's going to think we're trollers. Maybe a little bit. But yeah, why you can be anti-manual therapy, but bro hands on. I mean, come on, dude. Anyway, I digress. So how do we modulate pain? The one thing that research does support for manual therapy, if nothing else, is that it's like probably the best way to modulate pain. So why aren't we, and you talked about manipulating the back or hip is going to help the descending pathways to inhibit pain. It's going to help for quad activation. I'll let you talk about what articles those are in a second. How about mobilizing the patella? If especially people who are in pain, they're going to be tight, they're guarded, especially for some of these diagnoses. Well, what if we mobilize the patella or the tibia or the tibiofemoral joints and get some de-inhibition, decrease some of that tone, decrease some of that pain, allow things to glide and slide and move a little better. Maybe they're lacking a degree of extension that, we can't pick up on with our goniometers, right? Maybe there's something that's a little off, which the person will just tell you if you mobilize it and you retest it, they feel better, they feels normal. Maybe you're even outside the box mobilizations, and you hinted on it, a tibial rotary mobilization. Right, there is some rotation that should occur at the tibiofemoral joint. We're so conditioned to flexion and extension, but it actually has it's a triplanar joint. I mean, there should be some valgus and varus, obviously not too much. There should be some rotation. Obviously, we don't want too much. We're going to get ACL tears, but that is going to impact. If you look at the arthrokinematics and the biomechanical aspect of things, it impacts it the way it moves. So from that standpoint, it works. And then you mentioned nerve glides. Like what causes pain? What main structure in our body is what sends signals between the brain? We talk about, pain sciencing them, right? Pain is an product or output of the brain that's going to go through your spinal cord into your nerves. Well, what if we do some nerve flossing and alter that mechanosensitivity, biochemicals that are in there, even the biomechanics of the nerve and the properties? Can we help decrease that pain, make that window of opportunity so you can do your isometrics and then your eccentrics and then your movement re-education? So now it's a more comprehensive plan of care. Sorry. So, but before, we're on the fact of Osgood Shlatters and manipulating and manual therapy. If you could go into those articles, Jer, but then I want to move into probably, some of the other umbrella diagnoses as well, and some of the just really misconceptions and myths that hopefully we can help debunk and just open up our audience's eyes to maybe treating or adding treatment to what they already do.
All right. So first one being love me my ace. Which one am I sharing right now?
This is the IJSPT
Okay.
ACL reconstruction anterior knee
That's
pain.
what I hit, but it showed up the other two that I'm looking at. So
Well, you're sharing on the screen to everybody.
yeah. Okay. I just want to make sure I was on the right one. But
Okay.
so the article is named Lumbar Manipulation Exercise in the Management of Anterior Knee Pain and Diminished Quadriceps Activation Following ACL Reconstruction. Case report. Yes, it's a case report. I know you research purists will be like, it's not a meta-analysis or systematic review. You guys know our points on this. You can get a lot of value out of these sort of things. And unfortunately, let's face it, how many people are considering a lumbar manipulation for people with ACLs to do enough research to even hopefully even get randomized control studies. So we do find out there's a lot of value into these. Long story short, if you just want to go into, I don't want to go too much into it, sideline rotational lumbar thrust mobile manipulation may be beneficial. They showed improved quad activation in their handheld diometry. There's also been stuff in isokinetic labs as well. To top this off, AOMP did a great podcast with Dr. Ruggiero. I could be butchering that last name. So
Yeah,
I'm sorry.
I can never say it. I know what you're talking about.
And they did a case study on a patient that had AMI, arthrogenic muscle inhibition of the quad, which is common after ACLs. And they wanted to see what was eliciting the best quad activation with their testing, which I believe is handheld diometry. I could be wrong with that as well, but they compared with a patient NMES and then 3 exercises for 1 week. They did lumbar manipulation and then same 3 exercises. And then also, I want to say it was a tibial-femoral posterior mobilization. I could be wrong on that, but it was a local knee joint mobilization. Found all of them stimulated the quads. Beside NMES actually resulted in earlier fatigue of the quads. You gotta think you're doing it for minutes on end. But the lumbar manipulation, the most was the local. But in that case, and what they're suggesting, I agree with. Why not combine them? Why not combine all 3? Why not just quick manip, do a local mobilization, and then NMES to that? How many individuals do we get that get AMI because we're just doing, one faceted thing of just exercise or NMES, because that's what we've been doing for so many years. So that was a really, really cool thing that they kind of broke it down and tested week by week. In other studies, let's see, stop share.
Also, I'm going to say while you're looking for the next article, NMES. I mean, how about doing NMES outside the box? And I haven't done this in quite some time now. I just kind of moved away from NMES as a whole. But early on in my career, I would play around with it. And instead of just doing NMES for quad sets or straight leg raises, I would have people do like TRX squats and have like an ISO hold for that ramp up time of 5 or 10 seconds. And then have them, and it's a portable stim machine. So you put it in their pocket or whatever, and, have them do it that way, or a TKE, weight bearing TKE, or a lunge. Like if you want to do that, what about maybe something a little higher level? And granted, there's the argument of not, once they get to that point where they can actively stimulate their quad, maybe you should move them off it. But if you're just doing it in conjunction, there's no negative side to it. It's only positive. And yeah, that's just kind of playing around. I remember doing it with a low trap. I think it was low trap, mid trap activation with somebody doing a pull up. I did that. And then they had to do like an isometric hold at the top of the pull up. I think it was a CrossFitter I was working on who did that. But just kind of, playing around with some stuff and not always being just so basic with what we do. And I think, obviously we always preach about, pushing the envelope, challenging the status quo, layering or evolving what has been done. If if one aspect is shown to be effective, why not try the next progression or two beyond that and see what happens.
Yeah, no, I love that. And I think most of especially in the ACL realm with NMES is like, was it 90 to 40 degrees and that sort of stuff. I remember my CI was just like, that's not where they that's not where they have their issue with their quad strength. It's usually that terminal knee extension, as you said, or a weight bearing squat and everything like that. So I always have students that come in like, why aren't you doing the classic 90 to 40 degrees? I'm like, well, that's not their issue. I can see them do a long arc quad LAQ with relative ease, but those last 5 degrees of terminal knee extension, they can't do. So yeah, so there's gonna be some carryover, but it's not what they need to do is train the positions that they're having the most difficulty in. But God, Brandon, you look like you had a
last 5 degrees of terminal knee extension. I mean, you're the ACL study here, but what do we learn in biomechanics class or kinesiology class? What screw home mechanism, last 5 degrees, right? And that requires some rotation or movement of that tibia. And if they're lacking it, should we do our mobilizations to that? To open that window up, getting it glide a little better. And guess what? Your goniometer is not going to pick that up. Right. Our standard, right? So we're going to miss things because we're biasing ourselves basically against it. But if you just go in there and do, 5 oscillations, 10 oscillations, it doesn't take that long to do some of these interventions. Even if you're anti-manual therapy, you don't want to do it. Doing a lumbar manipulation takes 5 seconds. Yep. You're telling me in an hour you can't spare 5 seconds to do it? Mobilization maybe takes 2 or 3 minutes, and then you're moving on. I'm not saying there do it forever, but
yeah, that's the main thing. I mean, we're always, you're talking about productivity standards and like, oh, I got too much, people and that sort of stuff. It really doesn't take too long to do these.
If you're efficient with your treatment,
yeah,
you should be able to see and manage, 2 or 3 an hour.
But on the other research studies, there was a CPR and I think we talked about that in the previous podcast, so I'm not going to get too much in the weeds of it, doing lumbopelvic manipulation with people with a patellofemoral pain syndrome. Wasn't validated according to this and everything like that, but they did find differences in hip extension, hip abduction strength. And again, we've talked about that on the shows. It's like, I remember going through, I'm like, the whole thing of all the clamshells, all the bridges, changing up things. Shit, I feel so bad for all the people that probably borderline embarrassed by slapping NMES on their glutes, trying to get that to fire. And then look at, let me test, doing a manipulation or doing hip extension mobilizations and then trying to fire up those glutes. So, we're always trying to, as what you said before, sports strengthens us. Like, you cutting, you pivoting, you battling a defender, such and so forth. So if you don't think your muscles aren't firing during that, you're out of your mind. Something else, is maybe contributing to not as much activation. It's probably not just exercise because you're exercising enough. But let me see. I think there's one more, right? One more.
Yeah, the Iverson one. Maybe I have that one.
I think you have it. Oops. I don't know why I can see and can't see.
So this is the effects of lumbopelvic joint manipulation on quadriceps activation in healthy individuals. So now we're taking away any type of pathology, or hopefully taking away any type of pathology.
Real quick, and for people at home, that's it's by Grinstaff, effects of lumbar joint manipulation on quad activation on strength in healthy individuals. But we just taking a look at that. Can we extrapolate this and apply it to people with pain or injury? That group, the group that received a lumbopelvic joint manipulation, demonstrating significant increase in quad activation by 3%, force by 3%, activation by 5%. So that doesn't seem like much, But in the game where I say, especially like ACLs and that sort of stuff, that's a game of not inches. We're talking about a game of like centimeters.
Millimeters, yeah.
Little things can prevent, further issues. All right, I don't get that quad going. I don't get that full extension. Knees bent during walking, pisses off the joint, flares it up even more so. Joint gets stiff. They're going in for a manipulation under anesthesia, or they're developing a cyclops lesion. I firmly believe most cyclops lesions are more you didn't do enough in the appropriate amount of time versus, just bad luck. Having these in our tool bag, it can really prevent further issues. But I think that's the last of that research there. And you may have one more, right?
Yeah, I'll get to that in a second. When you were talking about the Crowell article, and sometimes how early on in your career you went to the glutes for anterior knee pain, which what's his name has a decent amount of research on that. I'm blanking. I'll come back to who it actually was, but even if you do subscribe to the traction and train theory, and the glutes are kind of what's stabilizing the femur and things like that, that's totally fine. That there's obviously truth to that, and for some people that's true. But if we're looking at you wanting to treat the glutes or proximally, we just showed you 2 articles that talk about increased activation of the hips or quads via manipulation of the low back and hip. So why not prep your patient with that, open up that neurophysiological window, now hit them with your glute stuff, bridges, clamshells, hip thrusters, lunges, deadlifts, whatever the case may be. But again, laying your treatment and stop biasing yourself against everything. I've mentioned this, I believe, before. I definitely mentioned in our courses, and I'm definitely in mentorship. Evidence-based practice isn't reading an article and following it to a T. Like, it's reading multiple articles and finding where and how to link them together, what parts overlap, what parts don't overlap. One study looks at one thing, another study looks at another thing that is relatable. Can you bridge that gap via what we know about neuroanatomy, neuroscience, biomechanics, et cetera? And not just, oh, well, this article said this, or this article didn't say this and didn't support it, and throwing the baby out with the bathwater, but trying to overlap the things that I've said. The more times I've tried to be, especially early in my career, learn everything, learn every different theory out there, the more I kind of realize, hey, there's a lot of overlapping and similarities here, and take a step back and look at the bigger picture. Like we said, regional interdependence, multimodal approach, hitting things from multiple angles. We're the human person, the human brain, the human body is very complex. So oftentimes hitting it, and this is not hitting it with a shotgun approach, totally different, where you're just throwing a bunch of stuff to see what sticks. But hitting it from sound rationale, looking at the impairments and hitting it from multiple different angles, is going to be more beneficial than not. Let me pull up and see if I have it here. This Iverson article. Here we go.
Building off of that, just understanding and knowing all the things that can potentially modulate and change tissues, can make an impact. Like, all right, you may not find any impairments in someone with a low back, with patellofemoral pain syndrome or any of these knee sore things. They may be able to bend forward, go over. You may even get in the nitty gritty and start doing UPAs. Nothing's bothering them and all that sort of stuff, but their knee bothers them. What's the harm in doing a quick technique and seeing if it can affect something down into the chain? It's just understanding and knowing that all these things can impact that, and that can give a patient confidence. We know manual therapy is mostly short term, the effects of it. So, but that confidence that gives an athlete or a non-athlete that, wow, they hit something further away and my knee's fine. Maybe all that stuff that the physician said about my joint being degenerated isn't necessarily all the true, because now after 5 minutes my knee feels that much better, and he even touched my knee, or she. So keep that in mind.
Yeah. So Jerry, you have no, all good. You have the privilege. So I just sent you the article.
Oh.
If you could just pop that open, and I'll talk about it.
All yours, big dog.
Yeah. So again, this is another one. Don't believe this was validated, but that's okay.
There's a lot of things aren't people out there.
Some things, just because, the factors that they looked at didn't end up being what they were. I mean, it could be, a sample size issue. It could be maybe they looked at the wrong factors. But these are things we need to be considering. Basically what CPR is trying to do is try and develop subgroups of patients who are more likely to respond to an intervention than not. All right. So if we're looking at that, I mean, our clinical prediction or predictors in this article, they looked at 5 here: difference in hip IR greater than 14 degrees, ankle dorsiflexion less than or greater than 16 degrees, navicular drop greater than less than let me backpedal. Ankle dorsiflexion greater than 16, navicular drop greater than 3 millimeters, no stiffness with sitting greater than 30 minutes, and squatting is the most painful activity. All right. So if they have 3 of the 5 present or more, they have a high likelihood ratio, 18.4. So anything over 10 is what we're looking for, of responding to this. If they have 4 or more, they have 100% chance of success. I mean, this is based off some of the numbers. Now, granted, it wasn't validated, but especially if you're hitting a wall with some of your patients or they're just not responding well, give it a shot, see where it works. I've had this work like a charm to some patients, and it's like, wow, this shit works. And I've had other patients where it didn't work as well, or it didn't work at all. Okay, that patient I'm not going to continue doing it on. Another patient I will. So you're not going to understand that or see that unless you're trying some of these things and you're utilizing the evidence, what the best of what we have to your best of your ability, and trying to apply it to the case in front of you. And that's what we want. That's evidence-based practice. That's operating at a higher level clinically and reasoning wise. Instead of trying to treat by diagnosis, we're treating by impairments. All those things I mentioned are impairments. They're asterisk signs, right? Instead of, I hear so many clinicians, oh, I have this diagnosis, I do this. So it's like a protocol. Or what would you do for this diagnosis? Well, evaluate the patient first and find out what's limiting them, because that main driver may be different for, a various patient.
Yeah.
So, yeah, I think
I get that on the phone a lot from parents too. They're like, how long is this going to take? How many visits and this and that, well, it really depends on once I see them, and I don't make that call until I do my manual therapy. I get someone, and I got a patient who, it was a deltoid ligament sprain, a bone bruise, was seeing PT, athletic training, everything like that. And with one mobilization, the one meal glide and weight bearing, symptoms were completely eliminated.
Yeah.
I did some icing on the cake stuff. Sure. Great. So at that point, I'm like, if your symptoms are completely eliminated right now, you can run, you can cut, and no problems. I don't need to see you a ton. So I, trying not to pigeonhole yourself. Well, I have to do X, Y, Z. I have to see them X, Y, Z many times and that sort of stuff.
I mean, I would say at a certain level, with a certain amount of experience, you can kind of ballpark what because you've probably had enough patients where you can say, well, they typically get better in 5 to 8 visits. This varies person to person. I'll know better once I treat them or evaluate them and see how they respond to what I do initially. I can give you a better timeline. But I think after if you're at a certain skill level and you have a certain amount of years and reps underneath you, you should be able to kind of ballpark it. Another thing I tell my patients too is they might not be better 100% in 3 visits, but I tell them we should know if what I'm doing you're responding to within 3 to 5 sessions. Most of the time it's less, but you never know what's going on. So if you're not making a change within 3 to 5 sessions, you need to reflect. on what you're doing. Even if you are making a change in 3 to 5 sessions, you still be reflecting and seeing, what's working, what's not working, where you need to pivot and change to as well. But, if you say typically this is what I do, and that's not being a salesman, it's being, confident in your ability to treat and get this person better in X amount of visits. Unlike an ACL post-op, well, that's going to be 3, 6, 9 months. By 3 months, they should be running 3 to 4 months. Like, if you can educate to your patient, well, on this, typically they're able to do this and this by this timeline, this and this by the next timeline, it goes a long way in just communicating and educating your patient and instilling confidence in you as a provider and what you can do for them.
Yeah, I think setting up expectations is super helpful for people. And then goes into the confidence the patient has in you after you explain these things. So I wholeheartedly agree. I usually tell patients, I'm like, most people know, I would say, you can agree, disagree with me, Brandon. Most patients know by the end of the first session whether this is it. It may not be obviously that first session. We're not God here, but where they know, like, we're doing something that eventually will lead me to the right path or get me to my goals and that sort of stuff. But
I've had plenty of patients, I'm sure you have, where they go to, a few other places. They're there for 6-8 weeks, not making any progress. And, you do X, Y, or Z in the first session. And like, I've done more in one session than, or I feel more accomplished in one session than 8 weeks over there.
Yep.
And that's a feeling, the patient is feeling that way, and it goes beyond, people skills and being nice to them. Yeah, that adds to it. And we're not saying those softer skills need to be ignored or should be ignored, but there's a difference when you do, quality therapy and interventions. They should have some type of change within that first session. I'm looking for a change in that first session.
Oh yeah.
So.
Well, any other nuggets about the anterior knee there, Brandon, in your clinical experience?
I would say, if you want your cookbook, get away from massage, get away from all that stuff, and make your cookbook. I'm going to manipulate this patient's back, hip, mobilize their knee or patella, and then I'm going to do, the isometrics and whatever other movement stuff you need to do. But like, you want a cookbook, that stuff should be in your cookbook, not a bunch of soft tissue stuff. And actually, I'm updating our spinal manip course now with some literature, and mobilization and manipulations have an effect on the muscle spindle and therefore the H reflex, and massage doesn't. So we're talking about neurophysiologically or neurophysiological effects as well as pain modulation. Well, the research is showing mobs and manips have that, massage doesn't, especially at the mechanoreceptors, proprioceptor level. And we're not talking about just mashing an area and you're altering the pain gate cycle theory or whatever that is, but I don't even follow anymore. But,
yeah. So again, just kind of really open yourself up to more interventions. And also throw in we say back, and it's not just the lumbar spine, especially for knees, even look higher. T-spine. I found some real weird stuff up in the T-spine that have, either referred or, painful on the involved side, and done T-spine manipulations if it made an impact. Hell, I've had an ACL, honest to God, where I've done a cervical manipulation and it's alleviated their posterior knee pain. A cervical manipulation, a standard up glide. So keep your doors open, windows open, mind open, all that sort of stuff. So especially it's one of those things where it's like, usually, especially maybe those longer cases and everything like that, a student just asked me once, like, when do you just chalk it up to like them being like, that's part of the process? And I'm like, yeah, longer things, Tommy John, ACLs, and that sort of stuff, they're going to go through their waves. But as long as you come in my door, I'm going to try and make things better. But yeah, maybe there's some soreness, they're experiencing, different capacity loads and stuff like that. But it's like session 2, session 3. If I'm blowing things off till session 3. Shame on me, but I'm going to look to make that better. Again, more from a psychological confidence standpoint, but it's also helping me to become a better clinician. All right, so maybe I figured that out, for a 6-month post-op ACL and, 3 sessions of them complaining about it. Now I'm going to hear it for the next one, and I'm addressing that right there and then.
Yeah.
And making it all the better for them. So, so just keep your ears and mind open there.
That's true. I have actually three points to that. One was to add on to your TL junction comment earlier, treating the TL junction. And I thought of your case report that you had where you treated the TL junction and you did the lateral femoral cutaneous nerve glide, and it cleared up their thigh pain. Well, pain inhibits muscle activation and strength, while they're not going to be as strong in their quads. They're not going to be able to perform their lifts. If this is a cutting athlete, this may lead to or be a precursor to an ACL injury, a meniscal injury or something, because that quad is delayed in firing. Yes, can we 100% prove all this? No, but we know certain things happen in pain and activation and limited, like, we can't do a study on, every person with low back pain, do they have an ACL tear? I mean, I don't think that study has been done, but that's hard to prove. Jeremy, I'll let you talk before I go on my other thing, because it looks like you have
the
some
last
stuff.
like 4 ACL tears. I want to say all of them have had an episode of low back pain prior to their ACL, like recently prior, not like years before. And or on top of that, we're talking about some other stuff, guaranteed ankle sprain. It's one or the two.
Yeah.
Start asking those questions of your ACLs. But Brandon made a huge point there, and I had to ask like patients that stuff that you get for like total knee replacements, ACLs, and like, oh, my back starts to hurt. Oh, it's from straightening, and you're like, oh, it's compensations. No, it's not freaking compensations. That back stuff was there prior to, and it's getting clicked up. Treat the damn back, treat the ankle, do whatever you have to do. But go ahead.
Going off on some tangents now, some bunny trails. I have a runner who had some hip and knee pain, and it's because they're arching the low back. They have no thoracic rotation or extension. All right, so they're getting all this stuff down the chain because they just can't move their thoracic, and they're over here foam rolling their IT band, and they bought Air Relax or Normatec boots, and they bought the Theragun, and they're just bruising the shit out of themselves up and not making any progress. I mean, what's that? Normatec's like what, $2,000, Hypervolt's $500, foam roll is what, $20, whatever. But that's, $2,500 on self-care. It's not even working because you're addressing the wrong things. Story. Actually, I had a patient right before Thanksgiving, came in with pain over the SIJ region, TL junction region, stiff as can be from T-spine down. So of course I'm going to address the low-hanging fruit. I clean that stuff up, trying to adjust that. The patient got like 40-50% better with that stuff, but she was like, it's still there. Her extensions still look wonky. Like it was improved, but she was avoiding something. And then we're talking, I'm like, all right, what else happened? What's happened? So she's like, well, I got hit in the head with a 2x4. It fell on me. Like she was walking through a doorway and it clunked. Going. I'm like, all right, well, you should have told me about this before, but whatever. I clear out the neck. I spend, 5 minutes mobilizing the whole neck down to CT junction, retest her. Goes from 40 to 50% better to 80 to 90% better right there. And her extension cleared up. And then at that point, it was just like, yeah, it's a little residual. I'm like, all right, let's see if that clears up in a day. I actually should follow up with her. But, not taking that 40%, which is still pretty good in the session. And like, there is something else. Let's look up the chain. I personally had one where my T-spine on my left side was cranky. It felt like every time I rotate, like a rib just wanted to like snap. Like it just, like you put any more pressure, this thing's going to break. Obviously it's not going to. I'm young, healthy. I don't have osteoporosis, right? Just felt that way.
Are you really young?
Young. I'm young. I'm not in the osteoporosis realm there, pal. I can't wait till I smoking in basketball. But anyway, so young-ish, right?
Youngish. Continue.
So we're treating the T-spine. I'm doing some flossing. It's just not going away. And I'm like, just treat my neck. Like it's been a little cranky. Treat my neck, treat my upper neck in rotation. And then did that and it just gone. So like Jeremy said, open up your mind. Don't limit yourself. Look regionally, right? PT schools taught treat above the joint, above and below, like go 2, 3, 4 joints above, below, or segments or regions, whatever, terminology you want to use. I had somebody, we're going away from the shoulder, or we're going away from the knee case. Someone with anterior shoulder pain. I had to mobilize T10, and for some reason that got their pain dissolved. I don't know. I can't explain it, but clearly something mechanically or whatever neurophysiologically was cleared up with that. But all right, we're going off too many buddy trips. Save this for another podcast
day. But awesome stuff. Hopefully everyone got some nuggets of knowledge, test some other things out versus just treating locally. And if you have any questions, comments, concerns, any points where you want to build off of, if you want those articles, feel free to message us and we'll send them over to you. Brandon, any last thoughts or announcements?
No, not for today. I think we're all set, man.
All right, cool. Well, we're off, and cheers, everyone.
Cheers.